It's lovely to be here. It's really nice to hear the story, first of all, actually, because there's a lot that you've just said that I want to pick up with people so that you know how to negotiate this if you can't get in touch with a menopause specialist. My clinic in the NHS has had a 650% increase in referrals since the Davina documentary. It's gone nuts. And we had to shut the door to new referrals. So I know that there's a huge gap between the need and the availability of the information. So although I normally talk about lots of different things, I'm going to focus on the medical bits in my chunk of the evening, because I know that nutrition and supplements and exercise will be dealt with really well later on. So just a tiny bit of background. I work in three settings. In the NHS, I work in primary care, secondary care, and in the private sector. And we, myself and my partner, Angela Sharma, we're both British Menopause Society accredited menopause specialists. That's important because actually there's lots of people saying that they're specialists that haven't had adequate training, and there's a real sort of mix of information and reliability of information that's available at the moment. I'm also trained in sex, which sounds like a strange thing, but it's actually really relevant at this point in your journey, because I did my sexology first, my training in sexual function and psychosexual therapy, and then I did my menopause training, because most of the time that I was using my sexology was with menopausal women. So the two things come together, if you coin a phrase, more often than you would think. And I'm actively involved in training and some voluntary work as well. So I'm going to try and cover tonight so that you have a proper understanding of some of the terminology, because not everybody knows what we mean when we're talking about the different stages. Menopause is a continuum. It's not a single event. It works over a number of years. You transition from perimenopause, when your hormones, which were previously really well choreographed. So most people in their menstrual cycles have got really predictable repeating patterns month after month. And when you get to perimenopause, it goes really chaotic. And some months your estrogen's high, sometimes it's low, sometimes there's progestogen, sometimes there isn't. So your body starts to feel really different. Menopause itself is just the name given to the last period. And you never know it's your last period until you've had 12 more months without another one. So most of the time you're making that diagnosis in retrospect. And then ever after, you're in the postmenopause. So crazy hormones, it dips, and then it stays low unless you decide to do something about it. And I'm going to talk a lot about HRT tonight, but it's not that I think it's the only way to do things. It's just that I'm here in a medical capacity. I'll talk about what you might not get from the other speakers. So when do you go through menopause? Well, the average age in the UK is 51 or 52. I said the median's 54. That just means that most of you will actually go through menopause a bit later than 51. But because we have quite a big chunk of young ladies going into menopause, it pulls the overall age down. Going into menopause early is not rare. Between 40 and 45 years is called early menopause. About 12% of women go through menopause at that stage. So that is just not unusual at all. And then the premature ovarian insufficiency people go through their menopause under the age of 40. The women who go through it early are different to those going through it at the sort of normal stage. They need to take action on their hormones, because if you lose your hormones early, it has significant impacts on things like bone density, heart health, and you become more at risk of particular health conditions as you get older. So they have a slightly different risks and benefits equation to go through. And in amongst these women are the ones who've had the really complicated, difficult journeys that I want to sort of mention specifically, like menopause after cancer, like menopause after surgery, or because of the hormonal injections we give people sometimes to treat things like endometriosis. Their menopause happens on the background of complicated health problems, and it is also like a crash. It's a sudden, severe, impactful menopause, which can be, and the studies show us, is more difficult to deal with. Do you need blood tests? No, not really. People will try and sort of sell you blood tests in private clinics or sell you kits to test your blood. But in perimenopause, it's all over the bloody shop. It's everywhere. So we can do a blood test one day that helps us, but then if we do it the next day, it may say that there's nothing going on. So we don't tend to routinely offer bloods to women over 45, but we sometimes look at those under 45 to try and work out what's going on for them. So symptoms, the first thing to say about symptoms is they're very real. They're not in your head. You're not going nuts. You're not sort of losing your mind. I get so many women that worry that something fundamental has happened to them and they've lost their grip. And it's a really vulnerable place to come in to sort of see a doctor when you're in that state. So just to underline, this is biological. There are things happening in your body and in your brain that are making you feel and act differently. You've got hormone receptors from your head down to your toes. So when we've been used to our bodies responding to a predictable pattern of hormones all of our lives, and then it starts to go really quite chaotic, we feel different in lots of different parts of us. So medically, we talk about vasomotor symptoms. That's your hot flushes. About 75% of menopausal women get those, but not everyone. And if you don't get them, it can make it hard to recognise what's going on with you. People talk about the flashes, like you say, it's like a furnace. It's like a heater being turned on. But you also get chills as well. And we don't talk about that as often, but your temperature can career down in the other direction and leave you shivering. It's to do with changes in blood flow because your body is no longer able to regulate temperature as well with less estrogen. And that impacts other parts of your circulation. So palpitations, facial pressure, feeling dizzy, getting migraines, all part of the same system. And I see loads of women referred to heart tests and so on because they've had palpitations and nobody really knew that it was just part of menopause. The psychological symptoms are literally the killer, actually. The psychological symptoms happen first, sometimes up to 5 years before your flushes and your periods start to change. So this is why women feel like they're losing their mind. They don't know what is going on with them, but they feel anxious. They're awake in the morning, at 3 a.m, worrying about things that previously never bothered them at all. They can't multitask anymore, whereas they used to be able to handle work, school, the kids' diary, everything else. Suddenly it's overwhelming. Mood changes, emotional ability, your brain is full of hormone receptors, so you're struggling to find words, to do your job, is all because of biological stuff that's happening. You're not imagining it. And I should just mention, actually, this problem is more of an issue in those of you that are neurodivergent, those of you that have got a trauma history. There are studies that say that women that have experienced adverse childhood events or trauma have a more troublesome time with symptoms as they go through menopause. And anybody that's progestin sensitive, I'm just going to sort of take a moment on the progestin sensitivity. If you've previously had premenstrual syndrome, premenstrual dysphoric disorder, which is a more severe version of that, a bad reaction to contraceptive pills, so you've got your mood changed on the pill previously, or postnatal depression, watch out, because you will have a more problematic time of menopause. We see increased suicidal thinking and suicidal behaviour. And if you get the wrong HRT, it can be catastrophic. If you get a progestin that you react badly to, I've seen frequently people with psychosis, suicidal ideation. So just flag it with your doctor that your mood has changed before with progestins so that people are more conscious of that when they're prescribing for you. Oh. Press that direction. Okay. I'm a sexologist, so I talk a lot about sex, but sex changes at menopause. I guess the key thing tonight, because I've not got lots of time, is to say, again, this is a real thing. So sensation decreases. It can be harder to climax. You can get more bladder infections after bothering to have sex. Your interest in sex can fall, and that can impact your relationship quite heavily. So be aware this is a biological thing. And even if you don't want systemic HRT, just using topical treatments like the gels, creams and pessaries that you use vaginally can make an enormous difference. Your clitoris is going to shrink. If you don't do something about it at this stage, it will really change going forward. So I just want to make you aware of that, really. Skin and joint system. It's a bit of a depressing bunch of slides, isn't it? Skin and joint symptoms. I find women think that they've aged 5 years as they've gone through menopause because they wake up in the morning, they feel stiff. All of a sudden, you notice your joints have aged. And that's because the hormones usually give you more sort of flexibility and laxity in your joints, and you lose that as you progress through menopause. So you can sort of feel like you're more uncomfortable. Skin gets drier, you can get more rashes. And I get lots of women quite upset about hair thinning. Body image and self-esteem can be quite hit by the loss of hair. And again, that's impacted by hormones, but also thyroid and iron status and nutrition and things as well. It doesn't stop there. It goes into your gut. So you can get bowel habit changes, bloating. Quite a large proportion of women get burning mouth syndrome. Nausea, dental issues. Your teeth can start to become more problematic because your mouth is drier. Eyes are drier. It affects all of us in all areas. How long does it go on for? Well, the average is allegedly about 4 years, but we know that perimenopause can be 10 or 12 years. About 42% of women are still symptomatic in their mid-60s. Half of you in this room will have about 7 years of symptoms. It's not a small thing. That's why you need to understand it. You need to know what your options are. And there is no arbitrary time limit for how long you can have treatment for. So no matter what your GP tells you, the guidance from NICE it's from 2015, so it's quite old and it's being rewritten, used to say smallest dose, shortest period. Scientifically, we've changed our view on that now. We now say you individualise it, you talk about risk and benefit with the woman, and you work out what she wants to do. So we should be following you, not the other way around. So I'm going to fly through HRT quite quickly because I haven't got much time. Why bother with HRT? Well, the main reason for most of you will be symptom control. It'll be so you don't actually have a car crash for 7 years. It's to get you to work, keep you in your relationship and stop your children from hating you. So it's quite a useful thing to go on to. But it also has an impact on your future risk. And this is the bit that gets blown out of all proportion on social media. It can be hard to work out what to believe in. So there's a complex bag of risk and benefit. For most symptomatic women, the benefits will outweigh the risks. So that's kind of the main message. If you look at a large group of women, and a study it looked at about 250,000 women on HRT and about 200,000 off it. If you look at all the things women die of, the group on HRT had a 9% lower death rate. So for most women, it's a good decision, but maybe not for everybody. You've got to sort of work out what your risks are for you. It reduces the risk of heart disease by 50% by the time you're in your 70s, going on to HRT. Women don't think about heart disease, but more of us will die of heart disease and stroke than will die of breast cancer. Only about 3.5% of women die of breast cancer annually, about 45% for heart disease, stroke and frailty. So you've got to get that kind of balance in your head about what to worry about. Reduces the risk of type 2 diabetes. It has some impact on dementia risk, but if you look at social, you'd think you're going to go nuts without it and you'll be perfectly fine with it. It's not as straightforward as that. The evidence base is much more sort of fine, but we think it probably does slightly prevent dementia if you start in the right time frame. It is massively important for bones, and women never worry about their bones. I hope you guys that are talking about nutrition and exercise might talk about bones, but bone risk is really a big thing for you. If you break a hip at 65, you have a 1 in 2 chance of living in sheltered accommodation or with assistance within 12 months, and a 1 in 5 chance of dying. And you'll be losing your bone mass from your perimenopause onwards unless you do something to protect it. HRT is one thing, but you can use exercise, calcium, vitamin D. There are other ways, but you must think about your bones, ladies. It's incredibly important. The golden window is the time when, if you start your HRT, you'll get more benefits. So if you can get your HRT started before the age of 60 or within 10 years of your symptoms starting, the evidence suggests that you'll get the heart benefits, you'll get the bone benefits. It's the right time to do it. Beyond that window, some women are symptomatic and will still benefit, but you don't get so much impact on long-term health. Breast cancer gets brought up a lot. It's the main drawback for HRT. Your breast cancer risk is different. Everyone in this room is going to have a different level of breast cancer risk. Some of it you can't change because you're born with it. It's your genetics. So those of you that have got family members that are mothers or sisters or fathers who had breast cancer or had it at an early age, under menopause age, it's very likely that their history impacts on your breast risk. Those of you that have got relatives further out or who had their cancer over the age of menopause, it's much less likely to impact significantly on your risk. Broadly speaking, that infographic there is what we go with, but it looks at the synthetic progestins. And as Lisa said, most of us these days go for body identical progestin, not synthetic. So hold that thought. But this is an infographic that tells you the background rate of breast cancer for women in their 50s, looking at 1,000 women in a 5-year period. So if we do nothing, we'll diagnose 23 cancers per 1,000 women in a 5-year period in their 50s. If I give that woman conventional, sort of old-fashioned combined HRT with a synthetic progestin, we'll get 4 more cases. If I just give it estrogen, we'll get 4 less cases because the relationship is quite complicated actually with breast cancer. But you'll see from the figures that if you drink a large glass of wine later when you get home tonight, that's the same additional risk that you're giving yourself. 4 more cases of breast cancer for 2 units of alcohol daily. If you exercise for 2.5 hours a week, you can reduce your risk by 7 cases per 1,000 women. If you're overweight and your body mass index is over 30, you're doubling your risk. So HRT can be considered in the sort of ballpark of those risks, and it helps you to make a more considered decision. If we use body identical progestins over a 5-year period, there's no impact on breast cancer risk. So that's why most of us talk about body identical as the one to go for. Oops, got to point it in the right direction. Hang on, flying through. So I'm going to fly through the different types of HRT. Am I all right for time for a bit longer? Yeah, okay. Just so that, if you can't get in front of a specialist, so that you know what you want to ask for, basically. So we have choices to make with HRT. You can either have it through your skin or you can have it orally. Most of us now prescribe it through the skin in the first instance. The major reason for that is that it removes the risk of blood clots. If we do it through skin, it doesn't matter if you have a migraine history, it doesn't matter if you've had a previous deep vein thrombosis or a clotting disorder, because it isn't going to change your risk of clotting. It's safe that way. It also gives you smoother blood levels, which if you've got mood sensitivity to your hormones is a really good thing. If you get migraines due to hormones, it's a really good thing. So going through your skin is generally better. Not everyone absorbs it that way, so it is not a disaster to have it orally. It just means that you have a very slight additional clot risk. It's very small, actually. And again, it gets oversimplified on social media that it's only through skin. Oral is okay if needed. Estrogen only versus combined HRT. If you've got a uterus, a womb, or if you've had endometriosis, and even if your womb's been removed, there may be patches of endometriosis left around, you need progestin. Estrogen stimulates womb lining. Progestin balances that. So if you've got any womb lining anywhere, you need both. Otherwise, if you've had a hysterectomy, you can just have estrogen. And actually, just estrogen alone is the lowest risk thing we can give you. And there is a difference, as I said, between synthetic progestins and the natural ones. Ideally, a natural one, which is utrogestan or micronized progesterone, is the thing to go for. Do you have to bleed? Can you not bleed? Broadly speaking, if you're more than 12 months from your last period, you can be bleed-free from the beginning. If you're still having some irregular bleeds or regular bleeds, or you're within 12 months, you need to go on to what we call sequential HRT or bleeding HRT. It's just so we don't all get our knickers in a twist if you bleed at the wrong time and start to investigate you and panic. We need to have predictable bleeding so that we don't miss womb cancers and polyps and things that need to be spotted. And the Mirena coil, which always divides women, I always get like the coil face when I mention a Mirena coil to people. It can be a godsend to some people, other people hate it, but it's often worth giving it a try because it can give you contraception, reduce the heaviness of your periods. And I have mood sensitivity. I used to have very heavy bleeds. Mirena's been a game changer for me. So it's worth considering it with an open mind. And for some women, it's great. You will still need contraception until sort of longer than you think. So you need it until you've been a year bleed-free over the age of 50 or 2 years bleed-free under the age of 50. And HRT does not give contraception unless it's the Mirena coil. So that's important to be aware of. Do you need it systemically or topically? I tend to give both because I'm a sexologist, but that just means, do you have it through your skin or orally to treat all of you, which is systemic? Or do you just want hormones given to the vagina and the vulva to look after that bit of you? I would say the gold standard is to do both, actually, but some women won't want to have systemic, but we should know that having it topically is safe for literally almost everyone, even women who've had things like breast cancers. Usually low dose is acceptable to the oncologist, and it's something that can make a huge difference to quality of life. You mentioned bioidentical. I just want to clarify that body identical and bioidentical are not the same thing. Body identical is licensed, it's prescribable, it's recommended by the British Menopause Society. Bioidentical is made in labs that aren't regulated. It's compounded hormones. We don't have much evidence for it, and it costs a fortune. So just watch the language carefully. Body identical is what you're after, not bioidentical. And then testosterone. Everyone, it sounds like everyone needs testosterone. I give out loads of the stuff in the work that I do. I'd say half of the women I give it to think it's great. The other half get rid of it because it makes them have extra hair or skin changes or does nothing at all. So some women really benefit from testosterone. It's good for sexual function. Some people feel like it makes a massive difference to mental clarity and energy. And I've seen that in lots of women, but the research doesn't show us that at the moment. So teething problems with HRT, lots of people give up early because of reasons like you mentioned, Lisa. So if you get the wrong progestin, it can make your mood not very good. So that could be a reason you stop it. Bloating, breast tenderness, mood changes, bleed problems, all really common. But usually if you go back and talk to somebody, we can reduce the dose, change the regime, balance it up slightly, and it'll be better. If you get bleeding in the first 3 to 6 months, don't panic. That's quite normal. About half of you are going to bleed at the wrong time when you start HRT. But if it's persistent and heavier, or if you're bleeding after 6 months, you must get it checked. We're seeing lots of women stop using their progestin because they don't like it and carry on with their estrogen, and that puts you at risk of womb cancer. So you must, if you're prescribed a progestin, you must take it. And if you don't like it, let someone know that you've done that, because we're quite worried about that risk out there. I was going to mention this, one more thing. Genitourinary syndrome of menopause, the thing that no one really talks about. On one side is what the vaginal mucosa looks like. So the sort of the inner lining of your vagina when you're in your fertile years is this really thick, bumpy, sort of cushiony lining. If we do nothing, we end up with something that's 2/3 thinner. We lose the little bumps and folds that let us stretch so that penetration isn't painful, and everything becomes much more dry and uncomfortable. The pH changes so we can get infections more readily. So just to draw your attention to the fact that this happens to everyone at some stage. It's not very proactively treated, I don't think, by doctors. So you guys might need to sort of shout for some treatment. You can buy it over the counter now. It's called Gina, but it's expensive. But if we don't treat this, you can get urine leak. You can find that you need to pee much more frequently than you did before, that you get more UTIs. Sex can become a bit miserable or joyless. And the treatment for it is topical creams, gels, pessaries. They work brilliantly and they can be a game changer. And I think that's probably all I need to do. Thank you.